Hello everyone. Today we are going to discuss our CTG series topics, and we will discuss today types of intrapartum hypoxia. Based on the rapidity of onset, intrapartum hypoxia is classified into following four types. 1. Acute hypoxia. A single prolonged deceleration with a sudden drop in baseline fetal heart rate less than 80 beats per minute persisting for more than 3 minutes. Such a sharp and long deceleration causes a rapid onset of metabolic acidosis if it occurs secondary to an intrapartum accident. And the intrapartum accidents are placenta rupture, umbilical cord prolapse, and uterine rupture. And the pH decreases at a rate of more than 0.01 per minute. The management of acute hypoxia, it has 4 steps. 1. Immediate assessment to exclude the 3 major accidents during labor, or prolapse, placental abruption, or cesarean scar rupture. 2. Correct iatrogenic causes such as uterine hyperstimulation secondary to an excess of oxytocin infusion or maternal hypotension due to anesthesia. Stopping oxytocin and considering administration of tachylysis, such as terbutaline, 250 micrograms subcutaneously will help resolve uterine hyperstimulation. And the administration of intravenous saline bolus will help correct maternal hypotension. 3. Change maternal position. And 4. Assess the CTG trace seeking for reassuring features, and these reassuring features are A. Normality in the CTG trace prior to deceleration. B. Variability is maintained within prolonged deceleration. Signs of recovery within the first 6 minutes of deceleration. If these reassuring features are present, in the absence of acute intrapartum accidents, the likelihood of recovery is up to 90% within the first 6 minutes and up to 95% within 9 minutes. The 3-6-9-12 minutes rule, which recommends measures to correct iatrogenic causes by 6 minutes and to transfer the woman to the operating theater by 9 minutes. If there are no attempts of recovery so as to compensate an operative delivery within 12 minutes of the beginning of deceleration, and to deliver the fetus within 15 minutes is based on this principle. Considering the drop of pH of 0.01 per minute, a baby subjected to acute hypoxia after 15 minutes will have a decrease in pH of 0.15, which could mean, for example, a drop in pH from 7.20 to 7.05. In case of a fetus exposed to gradually evolving hypoxia throughout labor, its reserve may be already compromised at the onset of prolonged deceleration. Therefore, the resultant fetal pH will be even lower. Subacute hypoxia, it occurs when the fetus spends less than 30 seconds on a stable baseline and decelerates for more than 90 seconds. Therefore, the fetus spends more time decelerating to protect its heart, with only 1/3 of the time at the baseline to exchange gases and to protect its brain. The shortage of sufficient time for oxygenation leads to the development of fetal acidosis with a drop in fetal pH at a rate of 0.01 per 2 to 3 minutes. Therefore, the fetal pH may drop from 7.25 to 7.15 in 20 minutes. When subacute hypoxia is diagnosed, hyperstimulation with oxytocin should be excluded. And in case of active maternal pushing, suggesting the mother to stop pushing for a while may allow the fetus to recuperate. Gradually evolving hypoxia. When a fetus is exposed to a gradual evolving hypoxic stress, it has sufficient time to mobilize its resource to compensate, starting with deceleration and loss of accelerations, secretion of catecholamines, which lead into increase in baseline fetal heart rate, to redistribute blood to vital organs as well as to get fresh oxygenated blood from the placenta. If this compensation fails, the onset of decompensation sets in, resulting in a decrease in perfusion to fetal brain. This will be seen on the CTG trace as a loss of baseline fetal heart rate variability. If no remedial action is taken, the myocardium will suffer a reduction in oxygenation with consequent acidosis that will be shown in the CTG trace as instability of the fetal heart rate baseline, culminating in a step-ladder pattern to death in terminal bradycardia. Long-standing or chronic hypoxia. Chronic cerebroplacental insufficiency and antenatal insults may result in hypoxia persisting for days and weeks, leading to attempts of compensation, chemoreceptor-mediated decelerations, and evidence of decompensation. These fetuses would have reduced physiological reserve to compensate for any further hypoxic insults and therefore may rapidly decompensate with the onset of uterine contractions, leading to a progressive decrease in fetal heart rate. Immediate delivery is indicated if features of chronic hypoxic are noted on the CTG trace. And if uterine contractions have commenced and immediate delivery is not possible, tocolytics should be administered to reduce further hypoxic stress until delivery is accomplished. Preterminal CTG, once the fetus has exhausted all its compensatory mechanisms, a total of baseline variability and shallow deceleration would be observed on the CTG trace. Due to progressive myocardial decompensation, the baseline heart rate will progressively decrease, and terminal bradycardia may ensue if delivery is not accomplished in time. This is the end of our topic today. Thanks for listening. If you're interested in these videos, please subscribe to the channel and press like. Thank you.